Okay, as people are logging in, I will start by welcoming everyone. Welcome to our Neonatal Hemodynamics Targeted Neonatal Echo Foundation curriculum. And we are starting the new year with what's going to be a wonderful presentation by Dr. Rios, and I will present her very soon. Just a few information that is quite important. First of all, the first part of the session, which is being recorded, will be available via the YouTube channel of the Neonatal Hemodynamics Research Center. This session will be a bit didactic, but we will have towards the end the opportunity for a Q&A with our expert speaker. So please make sure to put your questions in the Q&A box so that we're able to address them towards the end. Once we are done with the core presentation, we will have Dr. Rios and our fellows and young faculties, which are panelists, join a separate session, which is not going to be recorded. And at that point, we will also have Dr. Rusha Joshi, who is one of the fellows at Iowa for neonatal hemodynamics, and will be having the interactive case discussion with the panelists for the program of the foundation curriculum. So on this note, really thank you for being amongst us. We are starting a new year. We are starting with a really wonderful topic, which is the important physiological principles, which will be presented by Dr. Danielle Rios. So Dr. Danielle Rios is a professor of pediatrics in the Division of Neonatology at the University of Iowa. She's the director of the Neonatal Hemodynamics Clinical and Training Program. Her areas of focus in terms of academic research are the hemodynamics of critically ill neonates and the predictive analytics to improve outcomes of extremely low birth weight infants. And Dr. Rios, I just want to mention, has been a chair for many years of the foundation curriculum, and she's been really a driving force to really create wonderful content for our fellows in hemodynamics to kind of establish a bar which has been very high for everyone to maintain great content so that we can all learn similar concepts for hemodynamics in our respective programs. Now, before I give the microphone to Dr. Rios, I just want to mention if you could please keep your microphone and camera off during the presentation, number one. Also, I do want to thank my co-chair, Dr. Amy Stanford, who's been working very hard with the entire team to put together the schedule of the year and the objectives. I want to mention also the hard work of Laura Thomas and Megan Hudak, who are also in the background and working very hard for this event to be a success. Towards the end of this session, I do the panelists will have also the opportunity to provide feedback to us. So we do look at this feedback to enhance the content of these presentations. And last thing, these sessions are actually accredited by the Royal College of Physicians and Surgeons of Canada. So you would be able to obtain credits for the maintenance of certification when you're listening to these sessions and participating in these sessions. I think I have not forgotten anything. So I'm going to let now Dr. Rios take over for the presentation, and we will soon see each other for the Q&A session.
Okay, thank you so much, Gabriel. Let me just make sure I can share my screen.
We see very well.
You good? Okay, great. So I do want to thank Gabriel and Amy. So this would be kind of the first lecture of the 5th annual lecture series, and so now Amy is officially taking over as co-chair. And I want to say that it's been a great experience. I've really enjoyed kind of being able to co-chair first with Danny Weiss and then with Gabriel as well. And so I thank you guys for allowing me to kind of kick off this year of lectures. I'm sure it's going to be a fantastic one with the two of them at the helm. So let's talk about, what they kind of tasked me with, and that's the governing principles of physiology and neonatal hemodynamics. So I don't have any disclosures. Really, what they kind of said that they wanted me to talk about, and what I'm going to try to do during this talk is explain the relevance of physiologic principles in the assessment and management of hemodynamics, talk about some new unique features of the immature cardiovascular system, and then review some key fluid mechanic principles. I will also just kind of introduce us very, very briefly to the ACE guidelines. So first things first, it's important to recognize that the practice of hemodynamics is not about learning to image or to obtain echoes. Practicing hemodynamics means practicing physiology. So the most important aspect of becoming a trained hemodynamics faculty is understanding the why behind the pathophysiology you're encountering, and it takes many babies, many diagnoses, and variations of the same diagnoses, and a lot of time to accomplish this. So one day, Patrick McNamara, who I'm sure all of you know well, sent me this slide and told me that I needed to quiz the fellows on these principles. So while I refuse to do this, I know that this has become one of his favorite slides. He continues to enjoy putting this slide up, looking at the faces of anybody in his audiences, and realizing that many of them are recognizing that they're not able to match all of the physiologic principles that are listed in black to their fundamental concepts in red. But these are the principles that are rooted in the laws of physics and chemistry that provide a framework for understanding the mechanisms behind our biologic processes. So they are important. A key example of physiology in practice is that of the study of the activity of the human heart. So when we think about cardiac output, we think about stroke volume and heart rate, but when we're practicing medicine and making treatment decisions, those oftentimes rely on blood pressure. In some cases, just mean blood pressure are the decisions, but it's so much more complicated than that. When in a low cardiac output state, it's not straightforward what is causing it. So is it reduced preload? Is it contractility? Is it afterload? So this figure shows the multitude of causes of abnormalities in these three areas. But to simplify it, if blood can't get into the LV, you'll have reduced preload. And if the LV can't get the blood out, then you're dealing with increased afterload. And due to the physiologic principles that we'll get into during the next 25 minutes or so, these issues will lead to reduced contractility and or low cardiac output states. One of the early lessons in medicine is described as illness scripts, or the ability to recognize if the patient in front of you is sick or not sick. This is an important concept in neonatology, but also a difficult one to master. The important question we need to ask ourselves is whether or not the cardiovascular system is functioning adequately enough to meet tissue demands. But we also need to remember that symptoms don't equal a diagnosis. And when we see an abnormality in one aspect, this is merely a red flag that's telling us we need to investigate further to understand the physiology behind what we are actually seeing. This leads us to this depiction of the symptom-based approach often used in neonatology, and we hope that we're making a change in this with hemodynamics. But per the usual kind of neonatology way, if we see hypotension, for example, the knee-jerk reaction is I need to get fluid or I need to start dopamine. And instead, we should be asking ourselves what the underlying reason is behind the hypotension or the poor perfusion or the hypoxia. It doesn't matter what the symptom is. It isn't always clear cut, and until we investigate and have better methods of diagnosis, we're stuck with the lack of precision, since any of the diagnoses that are listed in that little thought bubble could manifest with these symptoms. But when babies look bad, everything has confounders. So what if I told you that all three of these babies that I have pictures of up on this slide had blood pressure that was within the normal limits? Does that mean that they aren't sick and they don't need treatment? Of course not. It means we have multiple layers of patients and illness. When we have well babies with low blood pressure but good systemic blood flow, we can observe them, but also know that they may be difficult to identify. The easiest group is those babies who have low blood pressure and low systemic blood flow. They obviously need to be treated. Another difficult group is the babies with normal or high blood pressure but low systemic blood flow. So this is when further investigation and identification of low blood pressure, low blood flow is crucial. So they often have an afterload problem that is contributing to the whole picture and sometimes making it tough to identify them. So studies have shown that mean blood pressure does not predict cardiac output, with this one specifically looking at LVO, or left ventricular output, on the left and SVC flow on the right. So just look specifically at the LVO at the moment, we see that there are babies with low mean blood pressure but normal cardiac output, and there's babies with normal or high mean blood pressure and low cardiac output. So let's try to understand why this relationship is not linear. Systolic blood pressure is the force exerted on the vessel wall during systole. Diastolic blood pressure is the resting pressure on the actual vessel walls. So systolic blood pressure is going to be influenced by cardiac output and is the blood pressure number to clue you into changes in cardiac output, while diastolic blood pressure is more influenced by vascular resistance. Mean blood pressure, on the other hand, is the time-weighted average of the pressure values during the cardiac cycle. Since diastole is longer than systole, the mean blood pressure is not actually the arithmetic mean of systolic and diastolic blood pressure. Rather, it's calculated via one of the two equations that you see on the slide. So this component of blood pressure is the one to give you the least amount of information, since you're not able to discern from it alone if the systolic or the diastolic blood pressure is contributing more to the number. Additionally, you may find larger changes in systolic blood pressure that are masked by a minimal change in the diastolic blood pressure, or perhaps an increase in the diastolic pressure. All of this is to say that monitoring the separate components of blood pressure is important in hemodynamics. And ultimately, blood flow to the organs is what is of the utmost importance. And we see complications derived from both either too low or too high of organ blood flow. So these are impacted not only by blood pressure and cardiac output, which we've discussed, but also by organ resistance or autoregulation. So let's go to a case just to highlight this concept. So we have a 25-week preemie that was born via emergency C-section for breech presentation and spontaneous preterm labor. The baby was relatively stable in low jet settings with minimal oxygen requirement and normal to high blood pressure values, as you can see here. A TN echo was obtained, which revealed strikingly abnormal physiology. So in this image, we see a dilated RV. So here's the RV free wall. This is your dilated RV with profound dysfunction. You can see it's pretty much not moving. And the team calculated the left ventricular output, the LVO, to be 70 mLs per minute per kilo, and the RVO of 16 with an extremely low TAPSE and RV FAC, or fractional area change. So this patient was actually maintaining their blood pressure with vasoconstriction, but had very low systemic blood flow and needed treatment. So how did we get into this situation? Well, we have important independent factors that all work together and then when you have low blood pressure, you can have normal, low, or high cardiac output. Same with the vascular resistance, and also cerebral perfusion. So the trick is to figure out where you are with each individual aspect and to decide if you need to treat this patient that's actually in front of you. So this is where hemodynamics comes into play. So as we now recognize the importance of cardiac output, let's go back and we'll discuss some of the founding principles. So Fick's law describes how substances move from areas of high concentration to low concentration. So Fick's first law explains the movement, and his second law describes how the concentration changes over time due to the diffusion. So the Fick principle states that the amount of a substance taken up by an organ per unit time is a product of the arteriovenous concentration difference by the blood flow to the organ, so using diffusion per se. Therefore, in the lung, if the arterial O2 content, venous O2 content, and oxygen consumption are measured, the cardiac output can then be calculated, as we see in this equation. So now let's look at this image depicting the Frank-Starling law by one of my favorite illustrators, Satyan. So we can see that an increase in preload has less, and diastolic ventricular volume has less impact when you're talking about even term neonates or the preterm neonates. So even more so in the preterm baby. In contrast to the increased contractility, stroke volume, and cardiac output that you can see following an increase in end diastolic ventricular volume in the adult myocardium. So adults are here on the left side of the curve, and then the term newborn is here towards the middle, and then the preterm is actually here on the mostly flat part of the curve. So I messed up. So looking at it another way, an increase in mean atrial pressure only increases neonatal contractility on the far, far left of the curve, which is a very small portion of the curve in relation to the adult, which you can see here up at the top. So for this reason, giving lots of volume when in the normal range of preload will not make a difference and may actually lead to adverse effects in the neonate. So exceptions to this do exist, and that includes pathology such as hypertrophy, and that's sometimes seen in infants of a diabetic mother. In addition, it can be pressure passive circulation such as Fontane's, which need this volume. So we hear about if neonates are unable to make changes in stroke volume by affecting preload, then that means that they must increase their cardiac output by increasing their heart rate. So this is one of the reasons that I've been told that physicians may have less concern about dopamine as a first-line agent, knowing it will increase their heart rate. However, as shown in this image, neonates are unable to increase contractility or force of their ventricular contraction by increasing the heart rate, whereas an infant is actually able to do so. So you can kind of see here the difference between the newborn and the infant. So this delineates the importance of identifying etiology and choosing the correct medication for that particular etiology in order to treat that patient, individualized medicine or precision medicine. So in the case of acute pulmonary hypertension, decreased preload will be a big contributing factor. So affecting pulmonary blood flow instead of heart rate would make more biologic sense for treatment in that case. So along the same lines, it's important to note that the myocardium in general cannot maintain contractility in the presence of dysfunction. So the relationship kind of goes completely out of the window in this case. So you can see here where you have cardiac dysfunction, you don't have any of that relationship. So if you're using medications for function that are increasing your heart rate but not actually improving the dysfunction, then you may actually be further compromising your coronary perfusion. So this is another instance where serial echocardiography or TNECO or neonatal hemodynamics, whatever you want to call it, can help guide your therapies and ensure that you're actually treating the physiology. So let's switch gears just a little bit. So this figure is looking at the differences seen in adults versus neonatal hearts. On the left-hand side, we see the neonatal left ventricle and the right ventricle versus the adult. And then on the right is the LV versus the RV. So both the left and the right ventricle are more sensitive to increases in afterload, as you can see here on the x-axis, afterload to contractility. But the RV is much more sensitive, both you can see in the graph on the left and on the right. So the RV is more sensitive to augmentation and afterload, and that results in a significantly bigger decrease in contractility. So this is also evident when we look at neonates versus children, not just up to adults. So the way to think about this is in weightlifting, where you may be strong enough to do a 12 rep exercise, but you'll tire out if you try to do continuous reps. So just, I'm going to do 10 minutes of weightlifting. So increased afterload is something that's encountered in all babies after birth, in those babies with acute pulmonary hypertension. And then in other situations where you might have sudden changes in loading conditions, and that can be like PDA closure after ligation or percutaneous catheterization. So this cute picture of Robert Hooke. So he gave us Hooke's law pertaining to myocardial compliance and to function. So Hooke's law states that the extension of an elastic object is directly proportional to the force applied to it. So F equals K, or the spring constant, times E, or the extension. So putting it into practice, the spring on the far right has twice the force due to twice the extension applied to it. So as the ventricle fills with blood, the pressure and volume that result from filling are determined by the compliance of that ventricle. So normally, compliance curves are plotted as a change in volume over the change in pressure, delta V over delta P. So for the ventricle, however, it's common to plot delta P versus delta V. So this is that figure here on the left. Therefore, the slope of the relationship is the reciprocal of the compliance, which is sometimes referred to as stiffness. So as the ventricle fills with blood and its volume increases, the pressure within the ventricular chamber passively increases as well. So this is the normal curve right here. The relationship is not linear, particularly at higher volumes, because the compliance of the ventricular wall decreases. So your stiffness increases the more the ventricular wall is stretched. So here's your increased compliance. You're not going to get as much, and your decreased compliance as well. So in ventricular hypertrophy, which is shown here in the image, the ventricular compliance is decreased. So the ventricle is stiffer because the thickness of the ventricular wall increases. Therefore, the ventricular end diastolic pressure is higher at any specific end diastolic volume. Alternatively, at a given end diastolic pressure, a less compliant ventricle would have a smaller end diastolic volume. So increased compliance, lower volume. You're not able to fill that ventricle as well. In firefighting, the Windkessel effect ensures continuous flow of water necessary to put out flames, which obviously is very, very important. So this actually is something that we can apply to cardiovascular physiology as well. So the heart acts as a pulsatile pump that propels blood into the vascular system during its contraction. The contraction is what we call systole. So part of the blood ejected during systole is stored during distension of the aorta and the proximal arteries. So the function of the large elastic arteries is to relay that contraction of the heart when it enters its relaxation phase, or diastole, thanks to their compliance. So after closing the aortic valve, the aorta and the proximal arteries retract elastically and restore the volume of blood stored. So this is the Windkessel effect, by which blood pressure is maintained and blood flow is increased in diastole, which ensure a continuous and non-pulsatile flow in the peripheral arteries and the capillaries. So on the top is your aorta that is very pulsatile, but you can see by the time it gets down to like the celiac, which is here on the lower part of that image, there's a much less pulsatility to it. It's continuous flow in that diastolic part. So now let's look at the relationship between pressure and flow, as described by Ohm and or Darcy, depending on the medium that they were, so geography versus electrical. So as the radius of a vessel decreases, here in the second image, flow decreases and resistance increases. On the opposite spectrum, increasing the radius results in decreased resistance and increased flow. So in the cardiovascular system, we use this frequently when we assess pressure, which is equal to flow times resistance plus the left atrial pressure. So to highlight this concept, let's look at this patient with acute hypoxemia and cardiomegaly on X-ray. So at the outside hospital, the patient was diagnosed with suprasystemic pulmonary hypertension and was started on nitric, but then he got worse and had signs of low cardiac output, including oliguria and lactic acidosis. So T and echo was done upon arrival to our hospital and showed an RVO of 600 mLs per minute per kilo and LVO of 365 with reduced RV function. So the TAPSE was 6 and the FAC was 25%. So the PDA was bidirectional with 70% left to right, consistent with suprasystemic pulmonary hypertension. But further imaging diagnosed the etiology of this being an atriovenous malformation of the brain. So in this case, the right to left ductal shunt was providing systemic circulation, and when nitric was started, that was decreased, resulting in worsened systemic blood flow to the kidneys and to the gut. And this manifested as low urinary output and increased lactic acidosis. So here you can see all the different images of the echo. So still talking about hypoxemia and vein of Galen malformation with pulmonary hypertension, this is how we deal with pressure flow relationship. So we have to identify the pathophysiology. In the one, the increased pressure is due to an increase in resistance. So these patients are likely to benefit from nitric oxide. But in the second scenario, the increased pressure is due to increased flow and not resistance. So if given nitric oxide in this case, there is likely to be harm due to a decrease in perfusion of the postductal circulation. So to make it even more complicated, we show that there are physiologies that are resistance mediated that may improve with vasodilators. There are flow mediated physiologies that would not likely be responsive to the vasodilators, but instead would require shunt modulation. But this is like the case we saw with the AV malformation just now. But there are three components to this equation, right? And so, of course, we can also have pressure-mediated pathophysiologies, which would require disease-specific therapies to improve the circulation. So any part of this formula could be affected in order to manifest as a pathophysiology in our cardiovascular system. So right heart for two of them, and then left heart would be your pressure-mediated. When talking about pulmonary vascular resistance, studies have shown that PVR, or pulmonary vascular resistance, takes 2 weeks to normalize after birth, as is shown on the image on the left. Additionally, on the right, you can see that PVR decreases rapidly, going from a low PaO2 over here on the left side of the x-axis to a normal range PaO2, but there's less change after attempting to increase the PaO2 past the physiologic range. So while this is normal physiologic transition, acute pulmonary hypertension with low pulmonary blood flow is not just a variant of this or a normal part of this. Acute pulmonary hypertension is a pathologic finding during the transitional phase and warrants treatment of the significantly elevated resistance in the pulmonary vessels. So there are three primary factors that determine the resistance to blood flow within a single vessel. So vessel diameter or radius, vessel length, and viscosity of the blood. So of these three factors, the most important quantitatively and physiologically is vessel diameter. Vessel diameter changes when vascular smooth muscle in the wall of the blood vessel contracts or it relaxes. Furthermore, small changes in vessel diameter produce large changes in resistance. So for this to be valid, however, the assumptions are that the flow is laminar, Newtonian, incompressible, and without acceleration. So this law is used to explain why constricted capillaries lead to higher blood pressure. This is also a concept used in PDA shunt mitigation, where increasing the viscosity of the blood with a higher hemoglobin can also decrease its flow. So Hagen was studying the same concept, but focusing more on the pressure drop. So this is actually sometimes referred to as the Hagen-Poiseuille law. Switching gears to the Bernoulli principle. So because flowing blood has mass and velocity, it has kinetic energy. So the kinetic energy is proportionate, or KE, to the mean velocity squared. So as the blood flows inside a vessel, pressure is exerted laterally against the walls of the vessel, and that's potential or pressure energy, P. So the total energy of the blood flowing in the vessel, therefore, is the sum of the kinetic and the potential energies. So there's two concepts related to this. So one, blood flow is driven by the difference in total energy between 2 points. And two, kinetic energy and pressure energy can be interconverted so that total energy remains unchanged. So this is the basis of the Bernoulli principle. This can be illustrated by a blood vessel that is suddenly narrowed and then returns to its normal diameter. When it's narrowed or stenotic, the velocity will increase as the diameter decreases. Blood flowing at higher velocities has a higher ratio of kinetic energy to potential energy. Because this is directly related to the diameter, if the diameter is reduced by 1/2 of the region of the stenosis, the velocity will increase fourfold. So because kinetic energy is inversely related to the velocity, the kinetic energy increases 16-fold. So assuming that total energy is conserved within stenosis, the 16-fold increase in kinetic energy must cause a reciprocal decrease in potential energy. So the fall in potential energy represents a decrease in the lateral pressure against the vessel walls. So an increase in velocity leads to a decrease in pressure, which is the basis for a Venturi effect, which I'm not going to talk too much about. So once we go past the narrowed segment, the kinetic energy reverts to its pre-stenotic value because the post-stenosis diameter is the same as pre, and flow is now conserved. So because of the stenosis, there's turbulence that's likely to occur, and therefore the post-stenosis potential energy and total energy will both fall. So when applied to fluid dynamics, the Bernoulli principle states that a reduction in pressure occurs as fluid flows into a region of increased flow velocity. So in the case of tricuspid regurgitation, the blood flow through the regurgitant valve is accelerated, and the Bernoulli principle is used to estimate the pressure difference across that valve. So we use the modified Bernoulli equation, which is delta P equals 4V squared, which is up there. You can't see my hands, but up here, looking at the RVSP. So here, delta pressure represents the pressure gradient. V is the maximum velocity of the tricuspid regurgitant jet. And by measuring that velocity, the pressure gradient between the right ventricle and the right atrium can be estimated. So the RV systolic pressure is then estimated by adding the right atrial pressure to that. In healthy term neonates, increased pulmonary vascular resistance seen for several hours post-delivery with mid or late systolic notching seen differently in scans done in the first few hours. The transition is complete by 24 hours of life with bidirectional flow seen in the PDA by the initial scan. So looking at LV and RV strain on the right, RV strain was significantly lower, though it also normalized by 24 hours. So in the healthy preterm infant, it's been shown that both the LV and RV functional parameters significantly improve between 10 and 45 hours after birth. This is a study done with 2 echoes at those time points. So let's switch gears to talk about that preterm heart. So in mature myocardium, on the left side, contractility is largely determined by the release of intracellular calcium ions, which are regulated by the surface L-type calcium channels, which cause extracellular calcium molecules to enter the myocytes after depolarization. So this leads to more intracellular calcium release from the SR. That leads to effective myofibril shortening and muscle contraction. So the sarcoplasmic reticulum lies close to the L-type calcium channels and responds with ease. Also, they have a T-tubule system that allows extracellular calcium to reach those intercellular structures. So when we look at the preterm heart muscle, which is on the right side, they must rely on the L-type calcium channels for calcium because they don't have adequate intracellular calcium stores in that sarcoplasmic reticulum, and they also don't have T-tubule systems. So it's also a higher surface area to volume ratio. So the preterm myocardium is also stiffer as a result of stiff collagen affecting their diastolic function too. So these differences together reduce the functional reserve of the heart in the face of stress postnatally. So here we'll look at isolated ventricular cells. In A is the diminished T-tubule development in the newborn versus an infant. B is looking at the sodium-calcium exchange, which is also diminished in the newborn, so in that first week of life. C looks at the sarcoplasmic and endoplasmic reticulum, the calcium ATPase pump in green and nuclei in red. And as mentioned previously, the neonate has just inadequate SR calcium stores, and this is one reason for that. On the left-hand side, the top image is a control infant heart, and this is sad, but the baby died in utero at 24 weeks gestation. So they stained it with hematoxylin, which is in blue, and that demonstrates nuclei, and Ki67 is brown to demonstrate proliferation. So the bottom left image is of a heart of a preterm baby who was born at 24 weeks gestation, but then died only 2 days later. And this shows the absence of that brown staining, indicative of the termination of proliferation. So on the right, the figure shows changes in collagen, cardiomyocytes, and capillaries during gestation. Cardiac mass due to hypertrophy instead results in shorter ventricles with reduced cardiac volume in adulthood. So once these babies are born, the proliferation of those myocytes just abruptly has an abrupt cessation, and then they just have to rely on hypertrophy alone. So look at this figure. The areas in yellow show no significant difference. And then you're looking at multiple time points with preterm versus term controls. And so there's consistent significant increases in weight index wall thickness when looking at a preterm heart compared to a term born control or preterms at baseline and term corrected age, with the area of altered LV myocardial thickness decreasing as gestational age at birth increases. So lots of differences between the preterm heart and the term heart. So a quick mention of the updated guidelines for targeted neonatal echocardiography. These were published last year in 2024. And while there's still participation and collaboration between hemodynamics and cardiology, in this version, the lead author is a neonatologist and hemodynamic specialist that we all know very well, and that's Dr. McNamara. And so delineated in this new version is the importance of physiology for understanding and practicing hemodynamics, which I think is an important aspect. So specific knowledge elements range from cardiovascular physiology and pulmonary physiology to different disease states, the etiologies behind those disease states, and their pathophysiology. For example, it talks about multiple different reasons behind having acute pulmonary hypertension or chronic pulmonary hypertension. So I think if you haven't already, pick up a copy of the guidelines and read through them. I think they're very important. So I just want to say that I am super lucky to be a part of the Iowa Hemodynamics program. And we have 8, soon to be 9 faculty, with Pearl's little floating head that's going to be joining us very soon. 5 of our faculty, including Pearl, have been recognized as fellows of the American Society of Echocardiography. And we have 3 fantastic hemodynamics fellows at the moment, and you will meet one of them as she is presenting pieces. And then just a quick save the date, because if you just want to learn more about cardiopulmonary physiology, we do have this annual conference coming up in November of this year. That's it.
Wow, that was an amazing review of some of the key principles of physiology that we need to consider at bedside and how they are integrated in our evaluations